outcomes have been. So are you sharing it now, Rachel?
Yes,
Okay,
can
thank
you
you.
see?
Yes, very clearly. Yeah. So the NIH treatment guidelines suggest that pregnant women should be treated, obviously, with all due safeguards and due consideration. They should be treated as somebody who's not pregnant when it comes to COVID. I think we saw two pandemics. One was last year's pandemic, which was without the Delta variant, and we had a different group of patients. I actually saw probably the first patient in South Carolina back in February of last year, transferred from Kershaw, 80-year-old woman. Next day, I saw her 84-year-old husband, late February, early March of last year. That was a different pandemic, I think, or epidemic last year, where we had nursing home patients, very few young people. But in the last 6 months, as Dr. Campbell mentioned, and all of you know already, that we've seen it's a different group of people getting hospitalized, younger people. Perhaps one of the biggest risk factors has been obesity. A high BMI, I think, is one of the biggest predictors of getting hospitalized and poor outcomes with COVID. And then you add pregnancy. Next slide, please. So this is just it's 12:25, so I'm not going to spend too much time on the treatment guidelines, but I'll talk a little bit about treatment guidelines. I'll talk a little bit about vaccination, talk a little bit about the booster, the Delta variant, and then show you some slide sets from the CDC dealing with maternal and fetal outcomes, which some of you are already aware of. So 32-year-old male, high BMI, bilateral pulmonary infiltrates. All of you have seen this, bilateral ground glass infiltrates. If you did a CT, you'll find ground glass infiltrates. Peripheral, less likely to be heart failure, especially in a 32-year-old requiring 4 liters oxygen. The recommendations are still that they get hospitalized, they get put on nasal cannula, they get remdesivir, although the data for remdesivir is slowly diminishing as to how much impact does it truly have on mortality. Yet it is probably the only antiviral we have at present. And we are still giving it to people if seen early. In addition, in somebody who has hypoxia, and I'll repeat that, if hypoxic, they must get steroids. If not hypoxic, they shouldn't get steroids. And this dose of steroids is 6 milligrams of dexamethasone. That was the dose looked at in the recovery trial. But whenever I go down to the OB floor and I see a young pregnant woman, or a pregnant woman, I always discuss this with the OB people, that there is nothing written in stone about dexamethasone. If from the OB standpoint, you prefer an alternate steroid for whatever reason, you can use alternates, and there are dosing guidance for prednisone or even solumedrol. So there is nothing written in stone about dexamethasone. You can use the equivalent doses. Prednisone would be 40, solumedrol would be about 32. And for somebody who's still getting worse on steroids, you should consider tocilizumab, which is IL-6 inhibitor, or baricitinib, if the oxygen requirement continues to get worse. Next slide, please. This is the data. This is the US data, the ACTT1 study. They published a final report about 11 months ago. And they found that remdesivir, when compared to placebo in hospitalized patients, did improve recovery time, reduced mortality, reduced 29-day mortality, and adverse events were fewer. However, recent data from outside the US suggests it may not be as good a drug as we thought. Yet, if somebody comes in early, within the first 4, 5, 6, 7 days, that is the viremic phase. That's the phase when the virus is the problem, not the inflammation. And I would say give remdesivir. The only contraindications to remdesivir are a creatinine clearance of less than 30. And the only reason is what happens is if remdesivir is given to somebody with an impaired creatinine clearance, one of the vehicles that remdesivir is given with, cyclodextrin, accumulates. And rarely, accumulation and renal failure of cyclodextrin can lead to hepatic necrosis. So monitor liver enzymes. It's very rare, though, to get true hepatic necrosis. I've given it to dialysis patients last year. And 5 days of remdesivir after a loading dose, relatively benign. How much it helps is still up in the air, but probably does help a little bit if given early. Next slide, please. And this is just the inflammatory cascade. It's a mind-bogglingly confusing slide, so we'll skip over it. Next slide, please. What about the inflammatory phase? There is the viral phase. And remember, the Delta pandemic is a bit different from the last year's pandemic. It's been shown that patients currently with the Delta variant have almost 1,000 times more viral load than we did with the wild type of virus last year. Not only do they have a higher viral load, they reach there early, probably day 4. The viral load is much higher, and they probably shed for a much longer time. And I think, in my opinion, I think the guidance for isolation should change, because there is data both from here and from other places suggesting the viral shedding goes on for a much longer period. So the older CDC isolation guidelines of 10 days for minimally symptomatic and 20 days for severely ill patients probably doesn't hold true. We have USC students here because USC students get tested just like MUSC, Clemson, etc. Some of them, young, healthy people, have been shedding high amounts of virus even at day 30 with the Delta virus. So it's a different pandemic. So regardless, in the inflammatory phase, i.e. around day 7, 8, if somebody has increasing oxygen requirement and they get admitted, steroids help. Multiple studies show steroids help. And this is the data from the recovery trial, came out of the UK, which completely changed the whole scenario. And you all know this. Benefit was greatest in symptoms in patients with symptoms more than 7 days, i.e. the inflammatory phase, and those who required mechanical ventilation. Next slide, please. These are just some Kaplan-Meier curves from the recovery trial. Basically, as you can see, that the dexamethasone arm had lesser mortality than the standard of care arm in all participants, those on mechanical ventilation. Can you see the mouse when I move it? You probably cannot, right? Because you're controlling it.
You can tell me where you would like me to put them.
No, that's okay. No, that'll get. But in the oxygen, and so you can see the one on the extreme right where it says no oxygen, the Kaplan-Meier curves are reversed. Dexamethasone arm actually did worse than the standard of care arm, correct? And that is why even now in the community you'll hear of people saying, oh, I got ivermectin. Well, if you're a horse, fantastic. If you're not a horse, then it probably doesn't help. Or my primary care physician gave me steroids. Non-hypoxic patients shouldn't be getting steroids, period. And I know that everybody's well-intentioned, they're trying to help, and there's so much misinformation out there, and I've got nothing against ivermectin. There is just conflicting data, and it's not enough. So let's talk about ivermectin for just 30 seconds. Ivermectin, antiparasitic drug, actually has in vitro activity against SARS. But the doses that you need of ivermectin to actually have activity against the virus are much, much higher than we can achieve by standard doses. There have been at least 20, 30 studies, probably 100 studies done around the world, India, Bangladesh, Pakistan, South America, England, Florida, Broward County hospitals. All of them have used different doses. Some use 200 mics per kg for 4 days. Some people use it for 28 days. Some did it with hydroxychloroquine. Some did it with azithromycin. There is no clear evidence it helps. So at this point, in general, the recommendation from the NIH and other groups is there is just not enough evidence to support ivermectin, either for mild COVID or for hospitalized patients. So we shouldn't be using it. I have about 6-7 months ago, I was on some calls with some colleagues in India. And when India was in big trouble back in March, I said, at that time, we actually said, you know what, it's okay to use 200 mics per kg, which is about 12 to 14 milligrams per day for 4 days, because India was in big trouble at that time. That kind of dose shouldn't hurt, but please understand that in the United States currently, there is not enough evidence to support ivermectin for mild, moderate, severe illness, period. And the data is still conflicting. Steroids, yes, all hypoxic patients should get steroids. Next slide, please. I'm going to talk briefly about tocilizumab. Next slide, please. Tocilizumab Studies that showed no benefit. There were multiple studies that came out in the last 1 year showing probably doesn't help. But if you do a deeper dive into the studies, they do show some reduction in mechanical ventilation. Some of them could not clearly show a benefit in mortality. And that's why the tocilizumab guidance said don't use it, and I said hold off. Next slide, please. And then came the recovery trial, the same group that gave us steroids from the UK, and those guys should get a Nobel Prize for, very simply, they did the steroid study and they changed everything for all of us around the world. Um, the recovery trial had 2,000 in the TOSI arm, 2,000 in the standard of care arm, and they found a reduction in mechanical ventilation, which has been shown with other studies. And they also showed a reduction in that holy grail, which is the 28-day mortality, 27% versus 33%. Another study, the REMAP CAP, which is actually a WHO, what they call an adaptive platform trial, where the WHO had about 80 countries doing various studies with different adaptive platforms. As newer data came, they would change the ongoing study a little bit. So these are called adaptive uh, platform studies, if you like, and they also showed a reduction. So in general, now you have a pregnant woman, 22-year-old, 32-year-old, or whatever, otherwise immune competent or a little bit of hypertension, um, gets admitted with the COVID, comes in, cough, difficulty breathing, and the cough can be disabling. You've all seen it. They're unable to take a deep breath, goes from 2 liters to 4 liters. Next thing you know, she's on air, high flow, requiring 50%. And that's bad stuff. You want to try and stop it as soon as possible. So the minute she hits the door, hypoxic, steroids, whichever steroid you want to choose, the equivalent of Dex, 6 milligrams. Remdesivir, yes, I would do remdesivir if they're within the first 7 days. If they're 14 days, there is no benefit. That is not the viral phase, that's the inflammatory phase. Tocilizumab, if 24 hours later she's still getting worse, or you suspect that this is heading in the wrong direction, I would do tocilizumab. A one-time dose, um, given um, 8 milligrams per kg times 1. Some people do a second dose, but most of the studies don't support a second dose. What are the side effects of tocilizumab? It is an IL-6 blocker. It can increase the risk of infections, but one dose shouldn't really hurt. Some other things to worry about: thrombocytopenia, somebody who has an active history of hepatitis B, untreated HIV, ongoing TB. But what's the likelihood? It's so low in the United States, right? You're not in India or South Africa. Um, um, and um, and then do the one-time dose. Gastric perforation and intestinal perforation is listed as a rare side effect. And some of that data comes from women who got tocilizumab for months and months and months for rheumatoid arthritis. So I don't think all that data on gastric perforations applies to a single dose. That data comes from women who got it for months and months for rheumatoid arthritis. What about preterm labor and harm to the baby? Couple of small studies suggest slightly increased risk of preterm labor, but it's very minimal. So the bottom line is yes, woman comes in, progressive hypoxia, remdesivir if early, definitely steroids, and then tocilizumab if available. Next slide, please. There's just a picture of a medical resident actually I saw last year with COVID, who had this is back in April of 2020 or March or whatever, doesn't matter. But you can see that his chest x-ray became progressively worse. Next slide, please. Just wanted to show you how tocilizumab can be very effective. You have EPIC at MUSC and other places. So you're familiar with EPIC, right? So this is just a snapshot of his vitals. All the red stuff is the temperature, the orange is the heart rate, and this is his respiratory rate on the right. Gave him tocilizumab around 8:30 p.m. See what happens to the temperature. Just go back to the same slide, please. This temperature disappears. Look at the tachycardia. The weight disappears and the tachypnea. Doesn't mean he got better and ran out of the hospital the same day. It took him about 5 days of coughing, coughing, coughing. But this just gives you an example of how these drugs can abrogate the inflammatory response, yet the lungs will take their own time to get better. It took 3-4 days. Next slide, please. So these are the guidance. You can also use baricitinib, which is a JAK1 and JAK2 inhibitor, if tocilizumab is not available. If it's not available, about 1 month ago, we were out of tocilizumab, but it's again available now. I don't know the situation and other colleagues who are from other parts, but it should be available. So I would use that. Next slide, please. So what are the treatment options for mild COVID to prevent progression and hospitalization? Next slide, please. Monoclonal antibodies. All of you are aware of this. This is the first, the bamlanivimab and etesevimab is the first Lilly product that was first approved back in December. So we opened our monoclonal antibody center in just 2 weeks before Christmas and ran it straight through Christmas because it was bad. The January-December surge was bad. Then came out the Regeneron product, the casirivimab plus imdevimab. This is the one that ex-president got in October of 2020. It's approved both by IV and sub-Q injection. And the most recent one is sotrovimab. It's a one-time IV infusion. All these are lab manufactured monoclonal antibodies. Basically, they take B cells from somebody who has had COVID. They take the genes from those B cells and they manufacture in the lab manufactured antibodies. And if I'm saying some nonsense because I'm not a lab guy, stop me, but that's my understanding of it. And basically lab manufactured antibodies that bind the spike protein so it stops it from replicating and reduces the likelihood of increasing virus. And by reducing the virological replication, you reduce symptoms, improve outcomes. Next slide, please. The monoclonal antibodies are recommended for all high-risk conditions, and pregnancy is clearly a high-risk condition. 2 weeks ago, like you folks, we were all running out of monoclonal antibodies. So we all formed a who is aware of prioritization in your hospitals for monoclonal antibody? I'm tired of speaking. It'll be great to interact with folks. So just unmute yourself, please. And were you all aware that we were running out of this monoclonal antibody about 2-3 weeks ago?
Go ahead and unmute yourselves. That is totally fine. Thank you.
And it's okay if you don't want to talk, but we were running out of it. So all of us, including MUSC, and I'm on multiple statewide committees that help with some statewide remdesivir, then antibody, etc. Everybody from MUSC, Spartanburg, Prisma, we are trying to figure out how to prioritize it. If you run short of monoclonal antibody, the first group to give it is the unvaccinated group. And in the unvaccinated group, those with high risk of progression, immune compromised, those who are on steroids, chemotherapy, organ transplant, COPD, and pregnancy. Pregnancy gets the highest score when it comes to getting monoclonal antibody. Next slide, please. And it helps. This is just some composite data. I'd made this slide about 2 months ago. If I'm going too fast, stop me. But you can see, again, you can't see the mouse, but if you look at the hospitalizations, in the monoclonal antibody arm versus the placebo arm, and you can see a significant difference and a drop and a decrease in hospitalization and death in the arm that got monoclonal antibody versus the placebo arm. So yes, monoclonal antibodies help. Next slide, please. This is South Carolina data. There's actually a little old. We are close to 20,000 now have been given. And we monitor this statewide. Over 19,000 patients with symptomatic COVID have received a monoclonal antibody in South Carolina. Only 40 were unable to complete treatment. No anaphylaxis, no serious adverse event. Once every few days, we have to give somebody a little bit of Benadryl. Rarely we have to give steroids, but I haven't seen a single anaphylaxis. And we have statewide data and nationwide data. And we have reduced hospital admissions, we estimate, and we have reduced number of deaths, we estimate. Next slide, please. And pregnant women are top priority, period, if we start running short. I just checked this morning. Today, we have adequate supply of antibody because it's supply and demand. We had a limited supply, increased demand 4 weeks ago. Now, as the numbers come down, we have more than enough for everyone. Next slide, please. And again, don't give monoclonal antibody to a 18-year-old healthy person who gets COVID. If they have no comorbidities, if they are not obese, don't have sickle cell, don't have COPD, they're not pregnant, I wouldn't give them monoclonal antibody. I don't think so. Because they will get better. But anything higher BMI, now the BMI, we talk about BMI of 25, anybody with a BMI more than 25, hypertension, dyslipidemia, sickle cell, cystic fibrosis, name any of those conditions, steroids, COPD, organ transplant, absolutely give the monoclonal antibody. Two words about this investigational drug. It is coming. It's probably coming within a week, within a month. It's called molnupiravir. It is an antiviral drug. It's oral. Remdesivir is only IV. It's an oral antiviral drug given to patients with mild COVID, can prevent or reduce the likelihood of hospitalization and death. Look at the results down here. Hospitalization 7.3% in the intervention arm, 14% in the placebo arm, and no deaths. This is striking. Look at the difference in deaths. So the independent data safety monitoring committee actually stopped the trial early, and that happens rarely, suggesting that they were impressed enough with the data that they didn't want to wait for the whole study enrollment. Is it perfect? There are some concerns that one of the byproducts of molnupiravir, called NHC, can have impact on viral mutations, but time will tell. It's coming, period. I think it's coming in the next month or so, it'll be here. What about people who haven't been infected, but have been living or have been exposed to somebody who's, let's say, 70-year-old grandmother, grandfather? And I had just had this call last night from someone. 70-year-old grandmother and grandparents actually live with a 10-year-old. Both the 10-year-old is now infected, and both the 70-year-olds in their wisdom did not get vaccinated. So they're unvaccinated and they're exposed to a 10-year-old kid who's infected. Obviously, they have to look after the kid because they have to feed him, water him, stuff like that. So now what? They would be prime candidates for post-exposure prophylaxis, where they've been exposed, they don't have COVID, and the same antibody cocktail that can be given to prevent progression of disease has also been approved to prevent infection. Next slide, please. So this expanded EUA covers post-exposure prophylaxis in adults and children who are at risk of progression and who are not vaccinated or who were on steroids and who have a high risk exposure within the last 4 days. So it's available, just FYI. Next slide, please. And then the same thing, molnupiravir is also being evaluated for post-exposure prophylaxis. Next slide, please. So what about mothers and babies? And so the CDC has the surveillance, and a lot of you know of this. Actually, how many of you are aware of this? Let me see in the chat. So how many of you are aware of this surveillance database? So anyway, this is a surveillance database called SetNet. It's a CDC database, and it has I forget how many jurisdictions, but we are one of them in South Carolina. And so these jurisdictions. MUSC or Dr. Campbell, are you aware of does this money go to the health department? I think so, right?
Dr. Campbell had to run.
Okay. I'm not sure where this money goes, but South Carolina is one of the sites, and they are monitoring for emerging threats from COVID, Hep C, syphilis, and Zika. And I'm going to show you. So next slide, please. This is data on COVID-19 during pregnancy. This is data on vaccinated women who got vaccine. Oh, sorry, this is DHEC. So somebody's put in DHEC does monitor COVID and pregnancy, and I'm guessing DHEC actually gets the funding also. So this is data on 29,000 women. 29,000. This is overall. This is not just South Carolina. Obviously, that'll be too much. They've got data on 29,000 women who completed pregnancy. 29,000 had live-born infants, 266 pregnancy losses. And again, I'm not an expert, and you are the experts in this, but I'm guessing that's par for the course. That seems to be a fairly that seems to be, is that number what you would expect?
Yes.
Okay. Next slide, please. And they also talked about number of infants born. So the slides got a little bit messed up. So the number of infants born term and preterm. And so this is term, the bigger bar here is term, and then the smaller one is preterm. Again, it seems to be fairly acceptable and what one would expect for baseline. And then lab testing of infants born to women with COVID-19. These are just some numbers, just FYI, this site is called SetNet, and they monitor other infections, including COVID. Next slide, please. So US vaccination status, you all know. Next slide, please. Keep going. I'm just want to get to the pregnancy. So a couple of words about vaccination versus unvaccination. I think it's very clear that vaccination, as you all know from your own hospitals, that 90–95% of hospitalized patients have been unvaccinated. There have been about 8–10%, for a while it was 12% who are vaccinated. Some of them were not fully vaccinated, but some were fully vaccinated. So there are vaccination breakthroughs, but the deaths in the vaccinated arm are extremely low. And so vaccination, next slide, please. I'll show you some more data on this. Next slide, please. So this is a Greek alphabet soup that, we talk about alpha, beta, gamma, epsilon, eta, kappa. There's also, just all this Greek alphabet soup, and delta falls into the variant of concern. And I'll show you some data on delta. Next slide, please. So what about vaccine effectiveness against the delta variant? So the bottom line is that the vaccines are still more than 85–90% effective against the delta variant and reducing hospitalizations. But as you all know, there has been a dip in the infections as we come to the 6–7 month mark after the Pfizer vaccine. So even at 6, 7, 8 months, Pfizer and Moderna are holding pretty strong against hospitalization around 86%, 88%, which is what we are seeing in real life. But the ability to prevent infections has probably dipped down to about 70–75%. So we're starting to see the vaccination breakthroughs. Next slide, please. This is vaccine effectiveness against hospitalization based on the CDC has multiple cohorts monitoring stuff either. So HEROES is amongst healthcare workers, Supernova, Vision, IV, NHS, and these are multiple cohorts monitoring groups of patients looking for vaccine effectiveness, hospitalization. And the vaccine effectiveness is in real life, efficacy in phase 3 studies, is still holding very well against hospitalization. But look at the bottom one, where against infection, it has dropped, and HEROES is a healthcare study, and then NHSN is a larger institutionalized patients, and it has dropped against infection. Next slide, please. And the same thing holds here, that overall, the vaccine efficacy has dropped against infection. As you can see, the delta, it has dropped down. Some people say 52, some others are saying 72%. And it has dropped for both the mRNA vaccines. Johnson & Johnson is holding about the same. It was about 65–70% 6 months ago, and it is holding fairly steady. It hasn't dropped as much as mRNA. So I think we will be getting boosters. As you know, you're already probably all got the booster for mRNA, but I think everybody's going to get it. And I'll talk about boosters in a second. Next slide, please. And I think we talked about this. Next slide. The breakthrough cases are happening. However, hospitalizations are still limited. This is DHEC data as of September 21st. Credit goes to Jane Kelly. Total breakthrough deaths are still very few. And this number on the right, bottom right-hand corner is pretty striking, that deaths are extremely low in vaccinated people. And that's the holy grail, I think, of this, or to reduce deaths, reduce the strain on the healthcare system. Next slide, please. They are safe and they are efficacious. This is data out at 6 months for the Pfizer vaccine compared to placebo. Next slide. And I can share these slides. What about pregnancy outcomes. So this is a study that looked at it's a summary of many studies, and on the right is sort of a summary. COVID has an increased risk of stillbirth, a higher likelihood of the baby going to neonatal ICU, a higher likelihood of the mother going to the ICU. So bottom line is it's a bad disease in pregnancy, and you all know that. Next slide. And this is the ACOG recommendations. You know this better than I do, but ACOG is saying all eligible persons should get the vaccine. And I have to say, even up until 3-4 months ago, I know of some groups of providers who were basically saying don't vaccinate. They were telling pregnant women don't get vaccinated. And that is just not right. And I think all pregnant women should get vaccinated. Obviously, it's a shared discussion with the woman. If she completely refuses it, that's fine. But every provider should be recommending it. And then it's a discussion with the patient. And the ACOG says if they don't receive the vaccine, it should be documented. You can give it at the same time as influenza, same time as Tdap. You don't have to wait 14 days. And all pregnant women should get the third dose. And that's right at the bottom. ACOG recommends that pregnant women, including pregnant healthcare workers, receive a booster dose of the Pfizer vaccine 6 months following the second dose. Next slide, please. And this is a joint statement published in August 13th. You're probably part of this. I didn't put the whole joint statement, but these are the signatories. I'm guessing you're somewhere, this group is part of this in some form or fashion, has to be. Next slide, please. What about breastfeeding? Breastfeeding women have, there is antibody in the breast milk. This is data on both IgA and IgG. And there is, at 4 weeks, 86% of women will have IgA antibodies of a certain titer in their breast milk. And by 4 weeks, 90% are positive in their breast milk for IgG. How much is the baby getting protected? We don't know yet. And maybe you can tell me more here, how much protection this offers. Next slide. So do vaccines prevent infection in pregnant women? This is a retrospect. So Israel did something very smart. Last year, Israel vaccinated everyone free very quickly. And so a lot of the data that we are seeing now on vaccine breakthroughs, on efficacy of boosters is coming from Israel. And this is a study out of Israel published in JAMA within the last, I think, 2 weeks, is a retrospective cohort study within the pregnancy registry in Israel, where women who got a first dose, not talking of the second dose, after the first dose, they were followed, and some of them went on to get the second dose. And the primary outcome was PCR, positive SARS infection. And there was a significant decrease, 118 in the vaccinated group and 202 in the unvaccinated group. And this is another study in the Lancet Infectious Diseases that also supports vaccinating pregnant women and reduces infection. Next slide, please. Are there increased adverse effects? Next slide. And the answer is not really. This is composite data from first, second, third doses of Pfizer vaccine. So first dose, second dose, third dose of Pfizer vaccine, and really very, deaths almost zero. And so it's a safe vaccine. Next slide. And this is an analysis of 35,000 pregnancies, no increased risk of miscarriage, stillbirth, or adverse outcome. This is published in the New England Journal about 3-4 months ago, where they looked at miscarriage, stillbirth, and there was no increased risk after vaccine. So once again, you can reassure your patients, which I'm sure you're doing already, vaccine is safe. Next slide. What about the third dose? Next slide. And you can tell your patients many vaccines require boosters, right? Hepatitis B requires a booster, shingles requires a booster, and so many other vaccines require boosters. So this is not unusual in the vaccine world. You give Tdaps to women every pregnancy, even if they're getting pregnant every year, they still get Tdap. Next slide, please. And so CDC recommendations are currently people over the age of 65 and those between 50 and 64 with certain underlying medical conditions. And you may give a booster shot to younger people who have underlying medical conditions or who are at high risk, like healthcare workers, teachers. So why this dichotomy? Next slide. This Israeli data, I'm going to skip over it. Next slide. This is the slide I just want to touch on for a minute, then we'll might have to stop because we're already almost done. So why not give a booster to everyone? We know that vaccine effectiveness against infection comes down. Vaccine effectiveness at around 6 months. Effectiveness against hospitalization is holding fairly steady, slight dip, but reasonably okay. But the likelihood of a older person who has a vaccination breakthrough getting hospitalized is much higher as opposed to a younger person. And the likelihood of a younger person getting myocarditis is slightly higher than the older person. So when you weigh the pros and cons, at the present moment, there is not enough pros and there may be more cons to be giving every young person the booster dose. That is why currently the booster dose is recommended for older people, since they are the ones who might have vaccination breakthroughs and get hospitalized, as opposed to a younger patient population where you don't have that much bang for the buck. Next slide. What if you've been vaccinated with Moderna or J&J? Moderna has submitted its EUA for the booster. They need more data on mixing doses. The Pfizer booster is the same dose as the original doses. Moderna will be not. Moderna has a much lower dose. Should pregnant women get booster? Falls in the category, yes, they should get boosters based on ACOG. And no, in the next slide. I think we'll stop because, by the way, you might be asked about fertility. It's a mRNA vaccine. It doesn't interact with DNA. It doesn't enter the nucleus. So it cannot interact with our DNA. It cannot turn us into robots or, cyborgs or whatever is out there. It doesn't enter the nucleus at all. It doesn't interact with our DNA. Women will not get infertile. And men, people have talked about semen count going down in men. If you compare COVID actually attaches to the testicular receptors, and it actually does not only multiplies in the lungs and the heart, also attaches in the testicles. COVID is much more likely to cause a drop in the semen count than vaccine. So again, this is bogus stuff. Next slide. I'm going to just, I think we're at time, just go forward to the last slide. I might as well put in a plug for for the telehealth. Keep going, just last slide, please. And this is the last slide. We do telehealth 3 times a month. We do a COVID grand rounds every week. That COVID grand rounds is attended and people from your institutions also speak. So I'll send Dr. Campbell, Dr. Johnson and Rachel the information. If you could please disseminate that. It's free, CME accredited, and we have people from Clemson and USC speak on this. And then we do Hep C telehealth. As you know, 1 out of 350 Americans have HIV, and about 1 out of 150 have Hep C, and all pregnant women should be tested for Hep C. So I do this, and we have a colleague from MUSC, Eric Meissner, who helps. In fact, he was doing one between 12 and 1 today, and then we have somebody from Vanderbilt, Cody Chastain, who helps moderate. But we run these telehealth programs. Too many slides. I didn't get time to cut them down, but it's a last minute thing, so apologies. But sometimes